Hello students, we're going to talk a little bit about the hip and a lot about the knee. So the hip joint consists of the acetabulum of the pelvis and the head of the femur. So it's a ball and socket joint. It has actions in all three planes. So from the frontal plane along an anterior posterior axis, we have abduction and adduction. So abduction is moving the femur away from the midline of the body in the frontal plane. Adduction is moving the femur towards the midline of the body in the frontal plane. We have flexion and extension in the sagittal plane. So that's along a medial lateral axis. The femur is moving anteriorly and superiorly along a medial lateral axis during flexion, and it's moving posterior and downward during extension. If you're starting in neutral, then extension is moving posteriorly and superiorly within the sagittal plane. Then the knee joint or the knee complex. When you hear the term knee, typically they're referring to the tibiofemoral joint. So that's made up of the condyles of the tibia and the condyles of the femur. They have the same name, even though they have different shapes. So this is rounded outward. So this is a convex shape on the condyles of the femur. This is indented. So this is a concave shape for the condyles of the tibia. But they fit together, and then we have the knee joint. So the knee joint is commonly called a hinge joint, but sometimes it's called a double ellipsoid joint because each condyle of the femur and each condyle of the tibia act as separate articulations, and they are shaped like some of our condyloid joints, like at the carpal metacarpal joints of the hand. So the actions at the knee joint in the sagittal plane along a medial lateral axis are extension and flexion. So straightening the knee could just be called extension. Bending of the knee is flexion. But then within those motions, because of the shape of the joints and especially how large they are, even though these motions to a very subtle degree happen in other joints, when you do extension, you also have an anterior translation of the tibia on the femur. So if we look at here and we go through extension, which is primarily a rotational motion, the tibia has to slide along the condyles of the femur as we go through extension. So that component is anterior translation. Then the same thing happens, or the reverse happens, when you go into flexion. The tibia slides posteriorly along the condyles of the femur. So that is posterior translation of the tibia on the femur. So during extension, it's a combination of rotational motion and anterior translation of the tibia on the femur. During flexion, bending of the knee, a combination of rotational motion and posterior translation of the tibia on the femur. We can have anterior and posterior translation by itself, but typically it's going to be very subtle, or it could be during a test, like to test if there's a ACL injury, or sometimes external impact on the knee can also cause that. But if we isolate it when the knee is straight, there should be very little translation when the knee is straight. But this would be a little bit of anterior translation of the tibia on the femur and posterior translation. If the knee is bent, there should be a little bit more joint play, and we would have a little bit more anterior translation and posterior translation. Then within the transverse plane, we have two new sets of actions. So we have, this is a right femur and tibia. So I have external or lateral rotation of the knee and internal or medial rotation of the knee. So that is along a vertical axis of the tibia. So remember, if we start here, the vertical axis for the transverse plane goes straight through the femur and tibia. If we bend the knee, we maintain that longitudinal axis being lined up with the femur. So the longitudinal axis of the femur, in the transverse plane of the femur, we have, in the longitudinal axis of the tibia and the transverse plane of the tibia, we have external rotation and internal rotation. Also, when we have those motions, we have motion of the patellofemoral joint, which is simply the posterior surface of the patella on the inferior anterior surface of the femur, and actually a little bit more of just the inferior surface of the femur if we're in full knee flexion. And this is fixed, so I can't really move it, but as I go through knee extension and the quadriceps pull up on the patella, that patella slides superiorly. So there is a superior translation of the patellofemoral joint during extension of the knee, or more specifically, superior translation of the patella at the patellofemoral joint. Then during flexion, have the hamstrings and say gastrocnemius, for example, are pulling back on the tibia. The quadriceps lengthen, and then we have an inferior translation of the patella at the patellofemoral joint. So that would be the patella sliding this way. So then some of the primary ligaments we have are the anterior cruciate ligament, which prevents excessive anterior translation of the tibia on the femur. And just for some terminology, sometimes you may see the anterior translation of the tibia on the femur being the same thing as posterior translation of the femur on the tibia. And that is true. So anterior translation of the tibia on the femur, that's excessive. And posterior translation of the femur on the tibia, also excessive. But you can see that they are the same relative motion. So this anterior translation is resisted primarily by the ACL, or anterior cruciate ligament, which would be in between the condyles here. And then the posterior cruciate ligament would prevent excessive posterior translation of the tibia on the femur. So here we have the ACL. It's going to be a little more anterior on the tibia and slightly more medial. And then posterior and slightly more lateral on the femur. So then if I try to do anterior translation, that tightens up. If I go through posterior translation, it loosens. Now, injuries usually come from anterior translation of the tibia on femur and some kind of valgus or varus stress, and often coupled with rotation. So anterior stretch or anterior translation. Then if I do a valgus or varus stress, that also lengthens it. So this would be a valgus stress. This would be a varus stress. They both put more stretch on that ligament. And if we add rotation on top of those other two stresses, those increase the likelihood of injury. All right, so then we also have the lateral and medial collateral ligaments. The MCL, the medial collateral ligament, so that's on the tibial side. Then the LCL, lateral collateral ligament, on the lateral side. So if I have, like at the knock-knee position, this is a right femur. So it would be this motion. That valgus stress distracts the medial side, which puts more stress on that medial ligament, and you can see that popped off. So that valgus stress is most likely to injure the MCL. Then if I go the other way, the varus stress compresses the medial side of the knee and distracts the lateral side. So a valgus stress, more likely to injure the MCL. A varus stress, more likely to injure the LCL. Then we have something called a I'll get rid of these. Something called a terrible triad, that is a simultaneous injury of the ACL, MCL, and medial meniscus. So it's usually anterior translation, a valgus stress, and then some kind of rotation. All right, so we're going to talk a little bit about active and passive insufficiency, and starting by looking at the rectus femoris. So that goes from the AIIS, or anterior inferior iliac spine, to the tibial tuberosity. So that would stretch with knee flexion. So it would shorten with knee extension. And it's anterior to the medial lateral axis of the hip. So it will do flexion of the hip. So if it does both, so a knee extension and hip flexion, it shortens maximally. And the more that shortens, the weaker that muscle gets. Well, somewhere past the mid-range, it starts to lose some strength. If you go into full hip flexion with full knee extension, that muscle gets significantly weak. It might start shaking. It might feel like it's going to cramp. That would be an example of active insufficiency of the rectus femoris through a combination of hip flexion and knee extension. So if you go the opposite way, knee flexion, hip extension, that's going to maximally stretch, and it may limit the total amount of either knee flexion and or hip extension due to a lack of length for the rectus femoris. So that would be a combination of passive insufficiency. So knee flexion, hip extension, trying to max range of motion. That rectus femoris might limit that motion, passive insufficiency. Then if we look at the hamstrings, all three of the hamstrings, we're just ignoring the short head of the biceps femoris, but semitendinosus, membranosus, and the long head of biceps femoris have to stretch through hip flexion and knee extension. And this will limit the range of motion that you can do. And well, typically if you're doing a stretch, you start with a knee extension. So it will limit how far you can go into hip flexion because of the stretch. That is passive insufficiency of the hamstring group. And then if we go the opposite way here, knee flexion, hip extension. Actually, that really shortens, so let's get a stretch here to start with. So knee flexion, hip extension starts to shorten. It's trying to contract. The hamstrings try to contract and fully shorten through knee flexion and hip extension, and they become weaker. Again, may feel like they're going to cramp up. They may feel shaky, but definitely a loss in strength. That is active insufficiency of the hamstring group.